My name is Braden Fink, and I am a third-year medical student here at the University of Nebraska Medical Center. Today I'll be presenting an approach to the workup of a common clinical finding on the wards, aortic regurgitation. This case offers an intriguing evaluation as the patient presents with multiple risk factors for valvular disease, including lupus, end-stage renal disease, and hypertension. To begin, clinical reasoning for the diagnosis and evaluation of valvular pathologies in young patients should encompass a broad range of etiologies based on an individual's risk factors. It is important to recognize that autoimmune diseases such as systemic lupus erythematosus pose an additional risk for significant cardiovascular comorbidities and require careful evaluation. This patient was a 28-year-old male with a past medical history of end-stage renal disease secondary to lupus on hemodialysis and hypertension who presented with shortness of breath for 1 month. On further questioning, he also endorsed a non-productive cough, orthopnea, paroxysmal nocturnal dyspnea, abdominal distension, and bilateral lower leg edema. A physical exam was performed which was notable for a diastolic decrescendo murmur, decreased breath sounds on the left, and lower extremity pinning edema. His blood pressure was noted to be severely elevated at 211/122 on admission. On further workup, his CHF peptide was elevated greater than 3,000, his white blood cell count was normal, and troponin was elevated to 74. EKG revealed sinus tachycardia. Chest X-ray showed a large left pleural effusion and pulmonary edema. To further evaluate his diastolic decrescendo murmur, a transthoracic echocardiogram was obtained which demonstrated elevated mean atrial pressures, a dilated and hypertrophied left ventricle, ejection fraction of 60 to 65%, and moderate aortic valve insufficiency with an effective regurgitant orifice area of 0.22 square centimeters. To further quantify the aortic regurgitation, cardiac MRI was performed which noted a tricuspid aortic valve with moderate central aortic regurgitation, an aortic regurgitation fraction of 22%, and a structurally normal aortic root. To look for potential valvular lesions missed on TTE or MRI, and given this patient's history of lupus, a TEE was performed and was negative for valvular vegetations. This patient initially presented with severely elevated blood pressure at 211/122. Following stabilization on Coreg, Entresto, hydralazine, and spironolactone, his murmur notably improved on physical exam. This case provides a valuable opportunity to consider the broad differential diagnosis of aortic regurgitation, which can include aortic valve degeneration, rheumatic heart disease, bicuspid aortic valve, endocarditis, aortic root dilation, and connective tissue disorders, including lupus. This patient presented with many risk factors which could be contributory to a presentation of aortic regurgitation, including end-stage renal disease, hypertension, and lupus. End-stage renal disease can lead to disrupted calcium and phosphate metabolism, which leads to hyperphosphatemia and hypercalcemia, which promote vascular and aortic valve calcification, which can cause aortic regurgitation. Additionally, fluid overload, common in end-stage renal disease, leads to left ventricular dilation, which can worsen regurgitation. Hypertension can contribute to left ventricular hypertrophy and aortic valve annulus stretching, further exacerbating aortic regurgitation. Finally, lupus patients are at risk for Liebman-Sachs endocarditis, a form of non-bacterial thrombotic endocarditis that can cause valve dysfunction and aortic regurgitation. Literature suggests that the prevalence of Liebman-Sachs endocarditis may be higher than recognized due to the limited sensitivity of TTE. TEE, or transesophageal echocardiogram, with higher sensitivity for detecting verrucous lesions, could be considered in patients with SLE with valvulopathy, such as aortic regurgitation. In conclusion, we recommend considering TEE in the workup for patients with lupus presenting with valvulopathy, as it has a higher sensitivity for detecting verrucous lesions to rule out potential Liebman-Sachs endocarditis. In this case, the patient's TEE was negative for any lesions concerning for Liebman-Sachs. This, combined with the patient's stabilization of their murmur following antihypertensive therapy, makes a most likely diagnosis moderate aortic insufficiency secondary to poorly controlled hypertension, and end-stage renal disease. The patient was discharged in stable condition with a recommended follow-up TTE in 1 year.